What's up, everybody? We're here with Dr. Natasha Bertel from King's Animal Hospital in Ontario. We have Dr. Ryan Bailey, anesthesiologist at Premier Veterinary Group in Chicago. And I'm Dr. Bini from Oklahoma State University. And I have my own consulting company, Safe Pet Anesthesia. Let's get started for this second episode of the Random Anesthesia Topic podcast. Today is going to be Dr. Natasha Bertel hosting. Actually, she has the random topic for us. I guess this deserves this, right? 100%.
100%. Okay, so a couple things before we get going tonight, gentlemen. One, I'm wearing the hat because my hair and my face are a problem this evening. But also, I'm wearing it in celebration of the topic tonight because this is a party topic. And I specifically picked it because it's going to antagonize Dr. Bailey significantly, which obviously is a good time for the rest of us. Now, I also want to have a big shout out for our first podcast, which got more than 0 hits. So that's a pretty super awesome. Yeah, right. And really, really cool feedback about clearly how hilarious / clueless the three of us are. But anyway, moving on. So tonight's
Let's not forget about the corn sweat.
Yeah, very important.
Listen, the corn sweat is really what drove it. So we need some sort of hook tonight too, guys. We need some sort of sweaty vegetable hook this evening to really like bring in our dozens and dozens of listeners. So I also want to show everyone my cool mug. Yeah, I have anesthesia themed mugs for the party tonight.
That's amazing.
That's a good one. I'll have to wear my anesthesiologist shirt.
Beanie's wearing an anesthesia t-shirt, so
I am.
Yeah. There you go. Safe Pet Anesthesia, our favorite telemedicine consulting service in a landslide.
Actually, big announcement. We got selected for the VMX Startup Circle for 2025. Oh. So only 20 companies in the US, startup, veterinary companies get selected. So
Beanie, this is great. For sure, AI won't displace you. I mean, Bailey and I will be out of a job in a year and a half, but you'll be fine.
Someone's got to drug those dogs, and it's probably going to be me. Well, I am just bones.
Yeah, someone needs to consult on the advanced analgesic care of Nubian goats. So, yeah. AI will be like, this is really not necessary. This is pretty redundant. I'll leave that to the real humans. But yeah, no, you know what? Live your truth. Live your truth. Speaking of truths this evening, we're going to be discussing one of my favorite pharmacological agents, well known for its high degree of utility in chronic pain. And you guys are like freaking out. And I'm just going to bring ketamine to the table.
Oh, okay. Oh. For a second, I thought that you were going to say gabapentin.
No, that's a whole other podcast of us bullshitting, and also just shitting on gabapentin and its complete futility. But yeah, no, tonight is ketamine. And where I really want to ruffle some feathers is discussing a lot of the myths around ketamine. And what do we actually know? Captain Evidence-Based Medicine is for sure Ryan Bailey. And, there's just a couple things that are probably not great for his blood pressure, but they crack me up. So we are going to start tonight with, right now, there's a big clinical movement for using subcutaneous ketamine in chronic pain. No vomiting allowed, Dr. Bailey. And so I'm just wondering what your guys' thoughts are on whether or not you think there's sufficient evidence to be promoting this. What kind of clinical efficaciousness have you observed? I mean, what are we doing here, boys?
We are like jumping right into like a hornet's nest for me. It feels like I'm gonna jump right on the grenade. I know that from what I have gathered, it is largely based on a small report put out by some people who are passionate about anesthesia and analgesia, and they reported that very low dose of ketamine sub-Q seemed to resolve some painful conditions. It is, in that situation, I think it is harmless.
Right.
Do you do it?
No.
Right.
But I use ketamine for painful conditions all the time. I do really like ketamine as a drug. Like, I love to use it in induction plans. I love to use it in management of painful conditions as adjunct agents during anesthesia when I feel our analgesic plan is not adequate, or where I think this patient is at high risk for a potentially chronically painful condition, or where I think just continuing to hose this patient down with opioids is not going to be beneficial for this patient's long-term outcomes. And where I think, yes. And
Time out. Did you go to Davis where they hose everything down with methadone even though it's non-painful? Like 0.8 mg per kg for like phaco emulsion? What?
I do use
Sorry, I had to. I really had to.
Like, what?
I mean, I also use opioids as respiratory depressants, MAC reducers, not just painful drugs like today in a
Are you using opioids as MAC reducers in cats, Bailey?
or don't. I put them on them and I say, let's cross our fingers and hope this is one of those few cats that gets the MAC reduction, but know that it's like, I don't know, based on the recent paper from Davis, opioids seem to increase sympathetic responsiveness in a variety of cats.
Oh no, here we go with Bailey and his crazy cat sympathetic tone situation. No. I'm reeling you back into the ketamine conversation because if you go on this tangent, you're never going to come off it. Beanie,
awesome.
what about you? I saw you hold up a big 0 sign there, and I'm just wondering what your thoughts are on the ketamine.
Yeah.
Italian version,
now,
by the way.
I can't. But what I always tell people is like, we know that the half-life of ketamine is like 45 minutes, something like that, at least in small animals, right? So probably an hour top, something like that. But, if you do it every 2 weeks sub-Q, like it's mostly placebo. If you do see any result, that's placebo, 100%. Like there is no, they base this stuff thinking of, in humans they do microdosing and whatever, blah blah blah, right? But that's like in a controlled environment. They're not doing it over 2 weeks sub-Q. It's a totally different ball game. People do hope that there is a way to manage our patients' pain long term without blasting them with NSAIDs, right? Or an opioid alternative, let's say. That's why they get hooked onto gabapentin, they get hooked onto like amantadine, this ketamine BS, it's, but the reality is that there isn't a way to do it, unfortunately. If you're looking for chronic pain management that is due to arthritis, thankfully now we do have Librela and Solensia out there that seems like they're having a huge positive effect out there. Every GP I speak with, they're really impressed with the results. There are some Facebook groups up there about cats dying after getting those injections. The reality is that the patients that normally do get those injections are really old, and that's when they get put on those, and so they die regardless of the injection. It's not the injections that kills them, but owners are trying to make that kind of association nowadays. So I don't know if you're aware of that, but there's that kind of train out there. But going back to the ketamine, I don't think that there is any evidence whatsoever. So
Okay.
Great
Interesting.
drug otherwise. Great
Okay.
drug for chronic pain management, intra-op, like, if you have a patient that, has been chronically painful and you want to use it, it's a good MAC reducer.
Here's a
Sure.
question. So for our 3 listeners out there, so one of the things that ketamine does is it modulates the activity at the NMDA receptor, which is going to be part of your pain pathway, so your afferent pain pathway. And in particular, it relates to, for example, pain chronicity, but also phantom limb pain in human beings. So that's one of the reasons why anesthesiologists will throw it on the recipe. Now, here's my question. Why are we not using it epidurally?
That's a great question. I'm not.
So
Yeah.
there is a paper out there that showed that,
There are a few, but they are like they're older than I
yeah,
am. So, yeah, like there was like this brief burst of ketamine epidurals in veterinary medicine in like the 90s, and then it kind of just abated. And no one's ever really chased it anymore. And I'm just, I'd like everyone's 2 cents on why that is.
love the reference. Love
Whoa.
how you slip the reference in. There is a paper out there, at least in humans, where it shows that they have 20,000. So ketamine and epidurally compared to morphine, it's 20,000 times less potent than morphine,
Well, that's
which
a
is
big
insane.
ass number. Okay.
It is.
But
It's
But what are
crazy.
we going for here, Beanie? Are we going here for acute pain management, so perioperative or peri-anesthetic, or are we giving ketamine in a mixed epidural so that we both get acute onset management and as well as we're mitigating the chronicity?
And
Good
we're stopping.
question. I
By the way,
think
this
I
is
think
me
it
just
also
bullshitting my way through this situation. I'm just asking a question.
I think so. Here's the deal. I think it all comes down to receptor distribution, right? It seems like there isn't enough NMDA receptor in, at least in the subarachnoid space, right? So that's where that paper was going into. Versus there is plenty of mu opioid receptors in that space. So if the drug can't reach your receptor, either an MDA or opioid, then it's not going to have the effect you want, right? So I think their thought was purely receptor distribution. Now, whether it's real or not, again, it's an old ass paper from the 80s, so God knows really. But that's my thought there. I never really tried it, so I would lie to you if I told you that I did try ketamine epidurally. Did you guys ever try it?
I've never. Yeah, I've never tried it. I
No,
mean,
I'm just stirring the pot.
it's a really interesting question. I mean, I don't know why we don't do it. I do like just lazily thinking like if they're not doing it in humans, there's got to be a reason.
Fair, fair.
Like they do a lot more than we do, especially for managing these like chronically painful conditions. Yeah, and so all this being said, like I use ketamine in the few like chronically painful cases, like I will put them on ketamine infusions and owners will report some degree of long-term pain management. So like this idea that the zero point 0.2 mgs per kg of ketamine sub Q is going to cause pain management, conceptually I understand why we would believe that, and I would I would like to see more evidence in this space, like more work being done on cases. I know these studies are hard to do, hard to study, hard like there's a lot of barriers, and I, for one, I'm just going to say I am not the person who's going to do it for a variety of
No, you're
reasons.
too busy doing your hot dog ranking system and obsessing about cat sympathetic tone. Like,
I mean, someone has to talk about hot dogs, or you know what?
Wait, 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 wait,
We're gonna be without hot dogs, and everyone's gonna be sad. So
Dr.
wait,
Beanie,
wait,
do
wait.
you not know about Dr. Bailey and hot dogs?
Absolutely not. And that's where I was going into. Now I need to know about this.
This is weirder than the corn sweat. No, he basically is on like this lifetime mission to grade every hot dog in Chicago, which Bailey defends as being
everywhere,
the home of the best hot dog.
everywhere.
But he will expand. Like if he's in another country, he will hot dog it up there. But like he ranks the hot dogs. I'm waiting for the definitive encyclopedia of hot dog rankings to come out. authored by Dr. Bailey. But that is like his one true passion.
If I'd only known I could have monetized hot dogs in some way. I mean, I've read books about hot dogs. I have books. I
You
have
read books about hot dogs?
dogs.
First of all, I did not know there were books about hot dogs.
Oh
So
yeah, there
I'm
was a
at a loss
comedian
here.
who went on a road trip in the summer during COVID and wrote a book about all the hot dogs she ate while on this road trip. It was called Raw Dog. It is a fucking hilarious book. And
Wait, what's the book called?
Raw Dog.
Raw dog.
I learned so much about hot dogs from that book, and I already knew a lot about hot dogs.
You know, the only thing that pisses Bailey off more than subcutaneous ketamine is putting ketchup on a hot dog.
Hell yeah. That's for children.
Yeah, don't fucking give ketamine and don't put ketchup on a hot dog. Bailey will just keel right over dead. Like his aorta will dissect like an overboiled hot dog, and that'll be it.
What do
The
you
aorta's
put
already like it's already on the verge because of all the hot dogs. I really upped my hot dog eating just to continue this dumb social media thing of ranking dumb hot dogs I eat.
No, next time we need to have like a hot dog contest. I want the live review from you, Ryan.
Bailey won a hot dog eating contest, and I was more proud of him that day than I was the day he passed anesthesia boards. I was like, now there's an accomplishment.
They were nachos for the record, but I was more proud of that than the anesthesia boards. I was like, I can't believe I won this nacho eating contest.
Oh, it was, I'm so sorry. It was nachos. He ran, I thought it was hot dogs, which is really gross. Like, yeah. Not to disparage people who are super eaters, but when you jam like 27 hot dogs down your gullet in 20 minutes, it makes me feel sick.
They're doing like 60 and 10, Bartel.
Get out of here.
Yeah, for sure. It's like a 10-minute contest, and like the record is like 60 or 70. It's insane.
Holy smoke. Anyway, Beanie is very stunned as an Italian because this is just the opposite of what he would consider to be haute cuisine. For our listeners, by the way, both Beanie and Bailey are outstanding like home chefs. Both could pursue secondary careers in like restaurant ownership and kitchen management. But Beanie is very European and Bailey likes to eat hot dogs. So that's where we really like.
Hell yeah.
The stream is diverging here. But so Gianluca, if you can't see us right now, is utterly horrified by this hot dog revelation. And honestly, I feel like he needs like some intranasal ketamine to come back down to earth.
Maybe just some sub-Q. Just a
little. You know, ketamine stings. People forget that, right? Like ketamine stings like the dickens when you give it. And like IM or Q, like there's reports of patients self-traumatizing because ketamine is so stingy. So it's like not something, you know, like if we're giving ketamine sub-Q and we really only have placebo results, you know, there's a minor merit in arguing that you're probably doing more harm than good there.
Yeah, that's a reasonable argument.
I thought that would make you happy, Bailey. I threw you the bone.
Thanks.
I threw you the bone. Yeah. Okay, next hard ketamine question. Cat with HCM. Oh, I'm not done. It gets harder. Cat with HCM, constant rate infusion of ketamine under GA, yay or nay?
Cats are just what in like I am obviously a cat person. I'm sitting in our office and there is a little felt version of Lucy that is on the desk.
Yeah, you also have a weird mustache, so that really speaks to being a cat guy.
Yeah, for sure. And, yeah, cats are just such challenging creatures, and like they are just like there's just like half your drug cabinet is challenging to say the least when it comes to working with cats. And so if I have a cat under anesthesia and I think they need a ketamine infusion and I know they have HCM, I feel like you have to weigh the pros and cons and like what like the simplest question I'm going to put back on you is why are we using ketamine in this cat?
Okay, well, that's a great question. So
Yeah,
for one of the things, and this could be another podcast debate, but generally
sure.
speaking, I do not put cats on lidocaine CRIs.
I
I
don't
know
either.
it. I know it can be done,
Yeah,
but my
I'm much.
gonads are just not robust enough to do it. Okay, and I'm not a chicken,
Yeah.
so that's gone. We
Mhm.
don't know whether or not opioids are they max sparing? Are they not max sparing? Okay, fine. I mean, if I
Increasing
turn
or
fentanyl up high enough, it's max sparing to the
tone.
point of death. So there is that. And then, question or not, I mean, obviously the other option is dexmedetomidine, but let's pretend we just operate in a world where dexmedetomidine isn't available, and I'm forcing you to answer the ketamine question.
Why are we putting the cat on ketamine in the first place? Is the cat challenging under anesthesia? Are we doing this as an adjunct analgesic drug in the plan before we even start the case? Is this a case where the anesthetist keeps saying the cat's temperature or heart rate and blood pressure are altering as the surgeon does surgery, and then they quiet back down? Yeah,
We could have a case where the patient is both, let's say we had poor outcome of our regional block. The patient's depth is getting to be problematic, and cats like to do that thing where they're markedly hypotensive and fucking awake.
yeah,
And right? And let's say it is responding intermittently with bursts of
yep,
your favorite feline sympathetic tone to various forms of surgical manipulation. And maybe we're doing an amputation where we might want to mitigate phantom limb pain issue.
totally.
Okay.
Like I don't think like I think
You keep
nine
trying
times
to avoid answering the question.
no, I think more 9 times out of 10 I'm probably going to at least consider, if not add, the ketamine infusion. I think if we have an HCM cat who's getting a limb amputation, I would have a ketamine infusion as part of that cat's plan. I probably would not use a high dose of ketamine as like an induction level dose, but I feel clinically when I give the lower, zero point 0.5 to 1 mg per kg, I don't see nearly the rate of tachycardia and sympathetic tone alterations that I see when you use those higher doses. And then you don't see those sympathetic tone changes that make me worried about this HCM cat when they're on these infusions, the 10, 20 micrograms per kilo per minute. So I'm pretty comfortable doing that, especially like if we're
Would
thinking
you
about the.
say the spectrum or the degree of the cardiac changes associated with the HCM may affect your decision?
I mean,
I mean, those doses you just quoted are basically sub-anesthetic.
right,
So, right.
which
And
is
so
what, which is where
we
I
don't
use.
really have good evidence about sub-anesthetic ketamine causing an issue with cats into HCM, just for the listeners to know. Like, there's no bulk of papers out there that looked at this.
Yeah,
So, as usual, this is our worthless 2 cents, but minus 2 cents. But yeah, like I'm just like, I mean, might err on the side of caution, for example, if the patient was dysrhythmic.
yeah. Oh, totally. Yes, for
If
sure.
we were close to congestive heart failure, I might pull back in
Yeah,
that particular instance. But,
I think if you
otherwise,
saw
like
like a
early
low,
ventricular septal thickening with
right,
like, you've got
yeah,
no atrial smoke, you've got nothing like, all of our cardiac output measurements are appropriate, ejection fractions, velocity, everything is normal.
yeah.
I think the summary is yes, I would. Bailey would. What about you, Beanie?
But wait,
Oh, he's not done.
one quick thing though. The only thing I just want to point out is like if you're saying this is a cat under anesthesia who is sympathetically responding to the surgical stimulus, and you are saying, I am going to withhold ketamine because I am worried that the sympathetic tone derived from ketamine is going to negatively impact this patient's cardiac, like already compromised cardiac system. I'm just going to let a completely fucking unregulated sympathetic tone to just keep going ham on this cat. Like, what logical sense does that make? It like hurts my brain when I think about it for more than 2 seconds. It's like, okay, I'm not going to give this drug because it affects sympathetic tone. Meanwhile, sympathetic tone is just like, and you're just like, what is going on here? Anyway, sorry, that's just my 2 cents.
No, and you made it emphatically,
That,
which we
that, that was
appreciate the
beautiful.
passion. Like, yeah, like, live your truth, Bailey. Like, you've got the passion for what, you love common sense and evidence-based medicine.
And hot
And of
dogs.
dogs.
Anyway,
And
So
cats and
Beanie would sure
mustaches.
put this cat on.
Wait. Are cats the bane of your existence?
Trick question. That's harder than the ketamine question.
But I love cats so much.
So
Bartel and I
much.
send each other cat memes all day long.
We don't even send anesthesia memes. Sometimes we send food memes. Once in a blue moon, if I catch a stinging hot dog one, I'll send that his way. But for the most part, it's 99.9% cats.
Before I answer that question, what do you put on your hot dogs?
Me?
Yeah, because if you don't put ketchup, what do you put on it?
Beanie's panicking. The Italian inside him is panicking because he didn't know about the ketchup rule.
So in Chicago, the classic hot dog is Vienna beef hot dog in a poppy seed bun with relish, onion, pickle, sport pepper, tomato slices, mustard, and then celery salt sprinkled on top. Now, there's a variation that I find quite good where we take off the tomatoes. We don't always add the celery salt, so it's just onion, relish, pickle, and mustard. Called the Depression Dog, usually served with French fries kind of rolled up into the hot dog. Those are like my two.
Well,
Those are my
Beanie, thanks for uncorking that bottle. Also, we know more about hot dogs than we do about ketamine.
Can you? So wait. Can you even taste the hot dogs after you put all the stuff in it?
Oh yeah, because the Chicago hot dog has like a spice to it. It's kind of like, it's not like hot, but it's a little spicy, and there's a lot of paprika and garlic in there. Oh man, you can definitely taste it. When you have like a shitty ass ballpark or like East Coast hot dog, tastes like dog shit. Like yeah, you can't taste it because you have all the vegetable matter. But it's because they were developed in the Great Depression. Because then you got a salad with your meal, and so you could get a hot dog for like a nickel. Man, could you imagine hot dogs for a nickel? I would be dead.
Yeah, Bailey, you should never get ketamine because I don't think your coronary arteries are going to take it. Good Lord.
But that's another great point is humans have so much more coronary arterial disease than our veterinary patients. And we get ketamine and people aren't afraid of it. I mean, I don't know.
Well, it has a massive safety index, right? Like your lethal doses of ketamine are like off the chart, and to have like any sort of form of like chronic detriment associated with like abusive levels of ketamine literally takes years. Now, when it does happen, your lower urinary tract necroses and sloughs out of your body, which does not sound like a good time. So I'm not condoning that, but ketamine really does have a very high index of safety from a point of view of clinical use. And I feel like people think that ketamine is like this like monster hammer of a drug that you only bring in for like pets who are really fractious or like you really need it to like drop them hard. And I'm like, just like a little whiff of ketamine really goes a long way, like a spoonful of sugar with a little bit of ketamine, like induction improves, your first like 30 to 40 minutes of anesthetic pain improve, like there's no rock and roll going on. You can, like people are so weird about ketamine and I'm like, ugh.
Well, anyway, Beanie, you got to answer the question. Are you going to put this cat
Sorry.
on?
He hasn't recovered from the hot dogs.
Yeah, I was in shock. Sorry.
Have you been putting ketchup on your hot dog? Because this is
what I usually do is
hell yeah,
ketchup and mayo together on my hot dog. And in reality, I don't do it as often as I would like to anymore because the only hot dogs we get are when we are in a rush, we're at Costco, and the $1.50 hot dog at the end seems like a lifesaver after you spend like 3 hours in fucking Costco debating with your wife whether you should buy or not the ginormous garden penguin for Christmas, the one with the scarf and the like.
I seriously hope that you guys got the penguin.
Well, I'm debating between the penguin, which is basically almost as tall as me, and then there is this ginormous teddy bear which is twice as tall as me, which is enormous. Also, we had this huge debate between the 7.5 foot, the 9 feet, the 12 feet, or the 15 feet Christmas tree.
Oh
Listen,
my
Beanie,
God.
I mean, if you're gonna do it, like, go hard or go home. No wonder you need a $1.50 hot dog at the end of this. Like,
The
this is a shocking state of
16-feet Christmas tree is like $1,600. I was like, "Cool.
Hell
You know
yeah.
how
I
many
can
hot
do
dogs you could buy for
Yeah.
that?
Yeah, a
Enough to
thousand,
kill you.
1,000 fucking hot dogs, straight up.
Just straight up 1,000 hot dogs. Yeah, you'd all be
I
dead.
shipped them to Bailey.
Oh my God, he would love it.
Hell yeah.
But okay, so Beanie, what are your thoughts
Yeah,
here?
I would
HCM,
totally. So
ketamine.
if the cat was responding to surgery, 100%, right? If I didn't have Dexmed, I didn't have fentanyl, I didn't have buprenorphine or anything like that, then yes, ketamine would be fine. I don't think that low dose ketamine, like in a CRI or even just small boluses, actually do cause the tachycardia that everybody's afraid of with HCM cats. Um, at least I've never seen it. Um, the other part of the story is that we do know that cats with heart murmur don't necessarily have heart disease. Cats without heart murmur may or may not have heart disease, and probably 99% of the cats in the world go under with kidney magic, right? DKD, where for whoever's listening, K stands for ketamine. So almost every single cat in the world gets ketamine at some point in their life, whether we know or we do not know if they have a murmur or not, or if they have HCM or not. So, like, I think ketamine is actually rather safe. We have this huge scare about it for the potential tachycardia that you can get, but as long as you don't go crazy with it, I think you're fine. I personally maybe wouldn't induce with it, like ketamine midazolam kind of induction. I would use I could do propofol ketamine, where the ketamine is just a co-inductor. I can use it at 1 or 2 mg per kg. Fine. Now I wouldn't slap 5 mg per kg in one shot in a cat, maybe, if I knew that it had HCM. But why not? Low dose, pain management, sure, whatever. For the record, what doses do you do normally for your ketamine CRIs?
Gosh, anywhere from 5 to 20 usually, although once in a blue moon, I'll kick it up to 40.
Yeah. I'm in the 10 to 20. I don't really get out of bed before 10 and then go up to 20 something. I mean, like, I'm sure you know, Beanie, but it's somewhere up in Canada where they go like 120, right?
It's
That's
OVC, which is just, a stone's throw from where I live. Not
Yeah.
really, but OVC is in Ontario, and they start most of their ketamine infusions between 20 and 40.
Yeah.
yeah. I think you're
Moderate.
talking about lidocaine. They go
Oh, maybe.
up to like 200.
I thought there was some.
Lidocaine, they do. They go up to 200. They start, 120 is their sort of moderate intermediary, but they will go up to 200. And they've published it, but
I thought there were some people that went up to like I think it's 100 and 120 where you're starting to get like actual anesthetic effects of ketamine. I think that's at least what I remember learning in residency. And I thought there's some group somewhere who does that not infrequently, but I could
well,
not.
let's not blame Canada, first of all.
No,
I mean,
I
we
just
only have like 3 vet
thinking
schools, so I
Canada.
doubt it's us. Yeah, and one's in French, so we'll never know. But but yeah, okay. And then, gentlemen, in the interest of time, let's move on to everyone's next favorite topic, which is ketamine and seizures and ketamine being neuroprotective. Beanie, I'm going to
Nice.
leave with you. What are your
So
thoughts? If you have a
I
patient with a
think
history of well-controlled seizures, will you put ketamine into your anesthetic protocol?
if it had imaging and I knew that it doesn't have an occupying space lesion, then yes, I could do that. If
And
I
just
believe there
explain
is
to the
not,
listeners why you make that differentiation about having something that's causing compression within the brain or within the skull, I should say.
so yeah, so like if your patient has a either an hemorrhage or a mass or something that increases the volume within the skull, of course you're going to have a potential increase in intracranial pressure. One of the goals under anesthesia for managing patients with potential increased intracranial pressure is to decrease cerebral blood flow. We do know that we do not really know what ketamine does with cerebral blood flow. There are studies that show that we don't know. Like, that's the legit answer there. There are studies that show that it does increase cerebral blood flow and intracranial pressure. There are studies that show that it decreases cerebral blood flow and intracranial pressure. So we don't really know. When I don't know, I try not to use it. And so that's my reasoning. If it's just a case of like idiopathic epilepsy, whatever. Actually, there are studies that show that high doses of ketamine are anti-epileptic. So, why not?
Yeah, that's the perfect medical attitude. Fuck it.
Oh yeah.
Fuck it. Let's see what happens. By the way, just kidding. That's not how we treat patients. Beanie, I'm getting the feeling that you agree with Bailey. Sorry. God, there's so many B's. Bailey, you agree? I'm a
Yeah, we
B
really
too.
should have thought one of us should have changed our name at least so we're not all just bees. We really should have thought about that one or just
No, I
recruited.
love it. I love Beanie Bailey Bartel. I talk about us all the time like that. It has nice alliteration.
I would definitely use it, especially where we know there's no space occupying lesion. Epileptic patient who's getting a TPLO, induced with ketamine, don't really care. Like, I'm not going to think twice about it, honestly. Now, if we have the patient who's needs an emergent brain MRI, was a potential vehicular trauma case, and someone's we're going to do rapid sequence induction, which whatever, taking terminology from the human literature, rapid sequence induction would be generally in humans seems to be propofol and ketamine as the preferred rapid sequence agents. I'm probably going to push back on that and question whether the ketamine's going to be super is it the best drug in that situation? I'll be honest, I don't know enough about the kind of neuroprotective stuff coming from the human brain trauma literature. So I don't
Well,
feel
it's funny that you brought that up because that was parlaying into my next question. Yeah, I was about to say that actually in rat models where they have induced traumatic brain injury, ketamine has been shown to have potent anti-inflammatory effects. In fact, it's meant to be anti-endotoxemic. Right.
Yep.
So in TBI, actually, there's quite a robust amount of literature that ketamine, even at higher doses, can be highly beneficial. Now, I'm going to counter that with, I don't know if you guys have ever seen a TBI who's on ketamine, but your ability to perform reasonable neurological assessment can be impeded because that patient who A, has swelling on the brain, and B, you just gave a dissociative anesthetic to, they look absolutely mental. So I don't know how neurology mitigates that. But at the same time, they really are whoop-de-doo, all over the kennel and what have you. So whether or not that's concerning, I mean, I could see it might be concerning if you had other fractures or other traumas, and then just thrashing around and being nutso on the ketamine might not be necessarily the most helpful thing. But yeah, no, I think there's pretty decent evidence about potent anti-inflammatory, potent anti-cytokine, basically anti-lipopolysaccharide, which is really the mitigator of endotoxemia. These are all things that we can attribute to ketamine in these models. So
Can I
yeah.
ask a question?
No.
All right, well, so then with the anti-cytokine, anti-endotoxemic, should we be using it in our potentially septic cases? Should we be using it more often? Again, I think all three of us are probably going to generally agree, I'm not going to be using ketamine to 5 mg per kg of ketamine midazolam to induce a patient, but should it be considered early on in these potentially septic cases?
Well, I'm gonna tease this out a little bit because there's that subtle difference between sepsis and endotoxemia, right?
Right.
And we don't actually get true endotoxemia in dogs and cats the way, for example, we see in horses, right?
Right.
So will I run my horse patients on ketamine if I suspect colic, sepsis, endotoxemia, because all of that stuff can really cascade quickly down the drain when you're under GA. Yes, I will probably be highly inclined to do so. But how often do I see true endotoxemia in a dog or a cat? I don't think I can answer that question.
What's in it, like the anti-cytokine, like those kinds of.
Yeah, and cytokines mitigate different parts of the inflammatory pathway. So it might be, most septic patients I put on ketamine anyway because I want to have ISO at 0.
Right.
If I can possibly manage it.
Yeah, for sure.
Yeah, so I think there's probably merit in that. I mean, a lot of the drugs are doing a lot of things that we probably don't know about, and in the most part, we're lucky because it's either benign or the negative, like the adverse outcome is irrelevant, or we're lucky enough to benefit in some way, right? So,
I mean, in reality, a bunch of these, neuroprotective effects are also seen in lidocaine in vitro, right? Never been proven in vivo from what I'm aware of. But, that was the reasoning why a lot of people will run horse colics with lidocaine CRIs. Now, that said, I do tend to run horses and also colics with ketamine CRIs. I usually start at 30 mic per kg per minute and I leave it there.
I love about anesthesiologists when we say things like, I sort of start at 30. And for our listeners, when you hear an anesthesiologist say that in that particular tone, it means I have no evidence for this decision other than that's what I'm comfortable doing, but I have no idea actually. Just translating for everybody.
Probably,
Yeah.
probably accurate. But anyway, but yeah, so, in places like in NC State, they've been doing this for years, right? So we would run every single horse, including colics, on Dexmed, ketamine, and lidocaine CRIs. That's because we want to keep their highs around 0 without killing us all.
Yeah.
But, But anyway, so yeah, so now circling back to your question, right? If you want to keep your highs at 0, why don't you fucking do Diva?
I mean, I'm basically, yeah, Tiva's fine. I'm all for Tiva, and I don't know what Bailey's doing right now. He's having some sort of Tiva meltdown, but he and I have gotten into it before about Tiva and thoracotomies. But yeah, I mean, I'm all for Tiva, but I'm not actually
I
gunning
had a
for
surgeon.
necessarily. It depends on, again, it's your spectrum of how sick your patient is. If you have like a colic who kind of walks in with like the symptoms and the sweating, and maybe it has like nephrosplenic entrapment, sure, I'm going to probably, be a little bit more laissez-faire with my isoflurane. So, I might use it only to mitigate the issue of unconsciousness, whereas everything else I'll use for muscle relaxation and analgesia, abated autonomic tone. I don't really think we get amnesia, but luckily horses aren't smart enough, actually, I think, to remember. So it's fine. But yeah, I think in the case of can you do Tiva? Sure. If they're very sick, I won't have them on inhalant at all. And sometimes the animal tells you that, right? Like you start on inhalant and you're like, oh no, this is a bad idea. And then the surgeon goes, how are things going? And you're like, well, the ISO's been off since you cut. So you tell me.
I had a surgeon that specifically didn't want thoracotomies on Tiva because they wanted to be able to smell whether there was a leak in the line.
What?
You know what? You don't have to be that smart to be a surgeon, and you can put that in the podcast. So
That is such a
that is the most irresponsibly stupid thing that I've heard probably since 3 o'clock today. There was a lot of stupidity earlier in my day, but yeah. Like, no, everybody who's listening, we do not intentionally wait until we can smell inhalation agents and we're 25 times over the recommended daily exposure limits, not to mention just chewing through the ozone layer with waste anesthetic gas. Like, we do not intentionally ever try to smell the inhalant in any circumstance. So a surgeon who says that, Should probably not cross my path in the OR.
What? It's like your sense of smell, like that's gonna be the thing that like, oh, there's a leak because I can sniff it. I got a real good schnozzle or whatever. But like the bubble test has been around for a long time. Like, what are
Yeah,
we?
right.
Yeah, that's kind of like, oh, I wonder if my, I wonder if there's a carbon monoxide leak. Maybe I'll just close all the windows and see if I can sniff that one out. Like,
Yeah,
absolutely not.
yeah,
Unacceptable.
yes,
Unacceptable standard of medical practice.
yes. Like when I listen for a leak in the cup, first of all, the ISO is not on because any number of reasons, and two, it's like I use my ear. Like I'm not
No. Yeah, no, I'm so antagonized by that comment, Beanie. Oh my God. Like I started to sweat in weird places when you said that.
You can imagine my surprise when I had to hear that. I was like, okay.
Also, I would
like,
appreciate if surgeons would stay out of the anesthetic protocol mix because it's basically like having your mechanic giving you gynecological advice. Like it's not appropriate.
King was on SIVO or like desflurane. Like, how good is he at detecting SIVO or des?
That
No,
could be a
maybe he's
study.
crossbred with some sort of like bloodhound and has like a high degree of sensitivity for this. But I'm like, no, this is not acceptable.
No way.
We do
Jeez.
not sniff out a problem, for God's sakes. We're not bomber dogs, people.
Oh, geez.
Wild. Yeah, there's
Some
just
people are
sometimes
wild.
that goes on. I'm sure it goes on in all anesthesia, but in veterinary anesthesia, it is extra mental 100%. Like,
Oh yeah.
yeah. I'm sad to say. Bless the hearts of all of us who do this job, but honestly, there are just days where I'm just like head shake. Just head shake and glass of wine.
Yeah. Just praying for the day the AI overlords come to take my job.
Bailey, you have the hot dog as a backup.
That's true. I could open a hot dog stand. I could probably do it. I've got the mustache for it
You
already.
could teach a
I do one of those
TED
cool paper
talk on
hats.
hot dogs. Yeah.
Oh my god.
You could teach a TED talk on hot dogs. I don't know
Yeah.
who'd listen, maybe Norm from Cheers, but that's about like, yeah. Like your level of hot dog knowledge is moderately terrifying.
So, do
Also,
you have any more questions about ketamine, or can I ask some?
You know what, Bailey? Have at it. Let's rock this.
All right. So we are we are probably all of the, I don't know, like the probably transitional generation of veterinary professionals where the people before us, ketamine was like a mainstay. Like ketamine was, that was it. That was what you had. And there
Cheap,
was no
cheerful, effective,
yeah.
available, probably wasn't controlled in those days. Yeah.
Just yeah.
Just fucking hosing it down with ketamine. Yeah, I hear you.
And like I will say as a student, I don't like as a student who was really interested in anesthesia as a student, I cannot say if I use ketamine and like, whatever.
really?
Yeah, I just don't know if I
Are you
did. I'm just trying to think. I mean, that was like so long ago now. I'm just like, I didn't use ketamine.
Where
And
did you
now
go to that school?
University of Illinois
Oh, nice.
with Clark Price and Jordan
With the
Besh.
cornbread.
Yeah.
Exactly. Um,
That's
uh,
the name of their football team.
well, the football team's in a transition because of the name. And I feel the new generations really don't like the way traditional ketamine inductions look because they're so used to propofol now and alfaxalone that you see these like patients who are like relaxed, head down, tongue, like no palpebral reflex, like they are anesthetized. And ketamine, they just don't look that way. And you get people who are not comfortable with this drug and they're pushing ketamine. And then the dog starts to have the psychomimetic effects. And then they're pushing ketamine and the dog has more psychomimetic effects. And like, he's still too light. I need more drugs. And you're like, no, you don't. You just need to get the tube in at this point because the dog is like loaded up on ketamine, I promise you. So like I don't know if I have a question there.
I was
More of a
wondering
statement.
if we were getting to the point soon, but
I feel like I think we've done a disservice just generally with like the advent of propofol and alfaxone, that ketamine has really, our just knowledge and use of it has fallen out of favor, and that I think is a disservice. And what can we do to, bring
no,
back the love?
I'm not sure. My opinion on the situation isn't necessarily driven per se from an induction point of view. But
But I
I
still
can
think
tell
that's
you
like
that I do feel like ketamine has almost been vilified,
yeah,
right? Like
yeah,
I don't know if it's because it's old fashioned. I don't know if it's because it's so weird though, because in vet med and vet anesthesia, people get upregulated about very specific side effects associated with drugs. And meanwhile, every drug has side effects. So we'll drown something in an opioid, even though you can have hypoventilation, bradycardia, hyperthermia, hypothermia, panting, emesis. Don't give a shit. Just push fentanyl until the patient is like recumbent and regurgitating. But like a little bit of ketamine, it's totally like, we don't need that. The patient's not that fractious. Or like,
oh
I don't
my
want to
God,
cause
yes,
tachycardia. And you're just like, first of all, if you're using ketamine at normal clinical doses and using it appropriately, oftentimes in conjunction with other balanced anesthetic protocols, I never see these tachycardic hypertensive explosions from ketamine. And so I'm like, I'll take it down a notch because we are okay with these side effects on this drug, right? But we're not okay with the known side effects that are less actually clinically relevant on this drug. And like I said, like you'll have people sedate with like 0.2 torb and like 2 of dexmed IM. And then you want to put it into a CT for half an hour and the patient's like, writing a book, and you're like, okay, well, let's just top it up with some ketamine. And they'll be like, I'd rather push alfaxalone.
oh
And
my
you're like,
gosh,
it makes no
yes.
sense whatsoever.
Yes. It's like we are anesthetizing horses every day with like ketamine, xylazine. Little put, 2 ketamine, 1 xylazine. Little push here, little push there. Horse stays asleep, nice and beautiful, wakes up super pretty. Everyone's happy. We move on with our lives. And it's like, oh, you want to, maybe we'll use some ketamine in this wound repair that's not going super well. And like we'll top it up with a little ketamine. And then once he starts getting rigid, we'll add a little dexmed for
And
some
it's
muscle
and it's
relaxation.
driven by other clinicians too, right? Like I've had other clinicians tell me, I don't think the ketamine is necessary. And I'm
Yeah.
like, what
Yeah.
is that statement based on? I don't think ketamine's necessary because it is really efficacious as a sedative and it's going to buy you like 30 to 40 minutes of the patient being still. And in conjunction with the torb and dexmed, you're going to get good relaxation. And then it's just going to wake up really nicely and go home. Or you'd rather just keep bolusing propofol until the patient goes blue and I have to intubate it. Like, it doesn't make any fucking sense to me. And it is super frustrating when other people are like, I don't think that's necessary. And I'm like, I sedate a zillion things a day for the last zillion years. And you're coming in this one time and giving me smack talk about ketamine. Where did this come from?
Yes, I'm telling you, I think it's a generational shift where ketamine was day bread and butter every day, all the time, and then it became out of favor because of the way the induction quality looked, and now it's like ketamine is reserved for like the wildest of the
Like, are you going
animals.
to do a zebu or a crocodile? Like, then you are allowed to use ketamine, but the rest of the time, like for the cat who'll take your face off,
Oh
oh,
yeah.
let's just titrate alfaxalone and see how that goes. What?
Yeah, I think so. I always push my students to try at least once in the rotation, ketamine midazolam,
But see,
and
at least
usually,
once, right? Why not all? Like, I mean, like for a variety of reasons. But it's just funny because it's like I get them to try it once. I'm the same way. I'm no different than you, B. I'm not like denigrating you. I'm just saying like we're all like, let's try it. Let's just try it. It'll be okay. Like I'll be right here. I'm not like, okay, kill this dog in front of me and then I'm gonna blame you for it.
but to follow up on that statement. So I
Just side
usually
note,
try to do
just a
this.
side note to all our listeners, Dr. Bailey is not in an academic position where he's in charge of training students. My word.
So I
But
always try to get them to try once, and I usually do it in the very first week of the rotation. And the answer I get afterwards when I ask them, what do you think? It was the same. Like they don't see any difference between propofol, ketamine, or propofol midazolam and ketamine midazolam. If you use an adequate dose of midazolam, I don't think that you see these major differences. I don't know if people got into the habit of using ketamine alone as a sole agent and hoping that they wouldn't be
as in a
rigid.
ketamine stun. Yeah, that is old school, and I'm not on
It
board for
is.
that.
It is. But I don't know if that's what scares people out. I don't know. I think it's a trend, really. But
Yes. Yeah.
I think we need to stop vilifying ketamine.
Oh yeah. That was my point. Is like,
Yeah.
that's
Well,
the
like
drug
I
that.
always rock up, like when I first went to Singapore, right? They didn't even have ketamine in anesthesia, and within the first month, we went through one of like the 100 ml bottles, and everybody was like, and now everybody's always like ketamine, 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 because I'm like it has high clinical utility and a wide safety margin, and it's highly beneficial. So this weird reservation for ketamine for only like the wackiest patients or the meanest animals, and it's like, why would you not rather do that than have to constantly top up a hypnotic agent where you could crash and burn them big time from that? I
Right.
recently had this ER case that came in, and it was one of those cases where I'm just like strolling through the room, like looking for snacks. And like this patient is on the table, and it's paradoxically breathing, and it's blue. And I was like, oh, time out. Like, what's going on? And they're like, well, we're not really sure. Anyway, patient had a tension pneumothorax from a lung perf from a foreign body, right? And I was like, they were like, we're not sure we should intubate. And I was like, okay, well, just to be clear, when the patient looks like this and it's blue, like it's time to intubate. Like you need to support it, otherwise it's going to arrest. Fair enough. But they handed me a syringe of propofol, right, to try and just take the edge off to induce it. And I just kept passing the propofol right along. And I was like, can you get me some ketamine? Right? Like I was like, I'm not pushing propofol. This patient will die. Right. And I was like, that is not the appropriate choice. And like that kind of level of respiratory distress that you're going to push a drug that induces apnea. I mean, the patient's already cyanotic, right? But it's like we treat propofol and alfaxolone like they're these almost like benign agents that you can just endlessly top up forever and there'll never be a consequence or a penalty. And I'm like, let me be clear. I will kill this dog if I push propofol. Let
Oh
me be
yeah.
clear. I will not kill it if I push ketamine and midaz.
Yep.
And ketamine's a bronchodilator, side note. So
yeah, a lot of people forget. I always tell my students in the lectures, like, it is one of the agents of choice in the battlefield, because they don't have access to oxygen. So they need to keep those patients breathing. They don't have a mean to intubate them and breathe for them. So that's what they use. If you get injured in the battlefield, they do use ketamine and some other agent. But
our next podcast, I really want to talk about battlefield anesthesia.
Yeah.
It's
Okay.
profoundly interesting the way that they choose to practice it. But yeah.
We should 100%, 100%.
Yeah, battlefield anesthesia is wild. Anyway, so the summary of this evening's random anesthesia topic is that we all really very much appreciate ketamine, often use it in first line therapy. A lot of the urban legends around the contraindications are easily mitigated through appropriate dosing and balanced anesthesia. And Bailey's probably going to have a coronary from hot dogs. So, yeah.
That's a perfect music.
That's hot dog music, Beanie. Like, that's what you play at
Yeah.
the gate when people are like jamming hot dogs down their gullet.
I am jamming hot dogs.
So weird. They're so weird. Anyway, yeah, like that's our random anesthesia topic. Bailey managed to get through it without dissecting his aorta or stroking out.
Nice.
But yeah, we love ketamine, bless its heart. I don't think any of us are overly excited about the subcutaneous ketamine placebo shenanigan that's hit pop. Like, I don't understand why anesthesia has these bursts of weird trends and popularities. Like we're some sort of Instagram phenomenon. Like, it was gabapentin and meropenem, and now all of a sudden we're on this subcutaneous ketamine like trend kick, and it's like
it has to do with side effects. It's like, oh, this seems like it has no side effects, so we should do it.
Oh yeah. I mean,
For sure. It's
I laugh because one of my surgeons was using the workstation in the pharmacy below the cupboard that had gabapentin, and he had to move his workstation because so many times a day people went into gabapentin, he could not get any work done. He was like, I can't focus. He's like, someone's in the gabapentin cupboard like every 14 seconds. And I was like, mm-hmm. Totally inappropriate. Total
That's
inappropriate
nuts.
use of gabapentin. But yeah, I was like, yeah, don't sit under the gabapentin. Don't sit under the gabapentin, everybody. You'll never.
And for those budding anesthesia residents, or the people who are smarter than me, let's do a study on this 0.2 mg per kg sub-Q of ketamine and see if it's like the home run, the hot dog, if you will.
Is ketamine, this is it, is subcutaneous ketamine the hot dog of the drug world?
Boom.
You know what, guys? Why don't we write the paper? And I'm going to call it, that'll be the title. VAA will jump at publishing that.
I mean, humans always have those like great names to their papers, like what was it, like the high-low study, or like the lung protect method, where like lung protect stands for like a whole ventilation thing.
Yeah, and our studies are always like this dose of buprenorphine in 4 healthy cats when isoflurane was at 1.4% under the case of lateralized spay, and like it's like the entire abstract is in the middle. And you're like,
Yeah.
I've already given up the will to live, and I haven't even read like results. So yeah, I mean, we could definitely publish is subcutaneous ketamine the hot dog of pain management.
100%.
I would never. It would be my proudest moment.
Me too. Me too.
Yeah, it would be
Anyway,
ate all the nachos.
I think we're coming up on the hour here. Thank you everybody for listening. Next time, I think Dr. Bailey is gonna pick the
I'm
random
ready.
topic.
I am ready.
I also want to know what's your favorite hot dog brand.
Uh, I
Like
think
if you were to make
Wait,
one.
was that question for Ryan or for me?
No, for Ryan.
Clearly.
Well, you can answer
He's the
after me.
expert.
But my opinion is the Vienna beef natural casing hot dog is the greatest hot dog.
Okay.
But
Can you find it
pretty neat.
in grocery stores?
In Chicago, you have to go to the Vienna beef factory to buy them, or you can
Oh
order them
wow.
online and pay like a
I
lot
never,
of
I
money.
never ordered the hot dogs online.
I had hot
Well,
dogs.
Jeannie, that's because you're a normal person. So, although you are discussing the merits of a 27-foot Christmas teddy bear. So, you know what? The summary is I'm the only normal one on this podcast, which is a real shocker.